Welcome to an evidence-based review of airway management. The 2022 ASA Practice Guidelines require a comprehensive preoperative airway evaluation to be performed and documented by the specific provider responsible for airway management. Single-test predictors frequently fail. To accurately gauge risk, we use a multimodal airway assessment battery, a structured protocol combining Mallampati scores, the Lemon criteria, and specific anatomical measurements to build a comprehensive risk profile. This diagram outlines the RHMD, or ratio of height to thyromental distance. Thyromental distance is the straight-line measurement from the chin to the thyroid notch. By dividing the patient's height in centimeters by this physical distance, we get a highly predictive score. A value exceeding 23.5 signals an elevated risk of difficult intubation. We also incorporate ultrasound point-of-care assessment to measure the pretracheal soft tissue at the level of the hyoid bone. A tissue thickness exceeding 2.8 centimeters directly correlates with difficult intubation, particularly in obese patients. Isolated physical tests miss critical anatomical variations. A strictly adhered to multimodal index provides the only reliable defense against encountering an unanticipated difficult airway after pushing induction medications. Based on this preoperative assessment, patients are stratified into one of 5 clinical risk categories, ranging from Category 1 for standard inductions all the way up to Category 5 for known fixed airway obstructions. For Category 3 and 4 patients, those presenting with multiple predictors or a known history of failed intubation, standard induction protocols are abandoned. The clinical mandate here is awake, flexible bronchoscopic intubation. This technique maintains the patient's spontaneous ventilation until the tube's position inside the trachea is definitively verified. Regardless of the assigned risk category, both the ANZKA and ASA require standardized airway equipment to be immediately available in all anesthetizing locations. This diagram breaks down the specific layout of the difficult airway trolley, or DAT. It utilizes a strict 6-drawer architecture with breakable sterility seals. Drawers 1 through 3 house advanced video laryngoscopes, intubating adjuncts like exchange catheters, and a full range of supraglottic airways. Drawer 4 contains the front of neck access, or FONA kit. Clinical rules dictate this drawer must be physically accessible within 60 seconds. It strictly contains a number 10 scalpel, a 15 French coude tip bougie, which is a semi-rigid guide with a curved tip, and a 6.0 mm cuffed endotracheal tube. Preoperative categorization dictates exactly how this trolley is utilized. By standardizing the equipment and locking its exact location, we eliminate the need to hunt for supplies during an active patient decompensation. When an airway emergency begins, cognitive fixation can be fatal. To prevent providers from repeating failed actions, we adhere strictly to the integrated DAS 2025 and ASA 2022 stepwise algorithm. Before making any attempt, high-flow nasal oxygen, or HFNO, must be applied. By delivering oxygen at 15 to 70 liters per minute prior to induction, providers facilitate apneic oxygenation, actively extending the safe apnea window. This flowchart maps the initial algorithmic response. Plan A establishes video laryngoscopy as the primary first-line device for all tracheal intubation attempts. It imposes a strict quantitative limit on laryngoscopy. Providers are restricted to a maximum of 3 routine attempts plus 1 expert attempt. Between these allowed attempts, the provider must actively optimize their mechanics. This means repositioning the patient on a ramp, changing the video blade, or applying external laryngeal pressure. Exceeding this 3+1 limit does not yield higher success rates. It simply increases upper airway trauma and hemorrhage, sabotaging any future rescue attempts. If Plan A fails, the sequence dictates an immediate transition to Plan B. This relies on a second-generation supraglottic airway, or SGA. These devices feature a built-in drainage channel to manage regurgitation, and insertion is strictly capped at a maximum of 3 attempts. Once Plan B is declared, there is an absolute rule prohibiting regression to Plan A. Failure of the supraglottic airway forces the transition to Plan C. This requires 2-person face mask ventilation, paired with an airway adjunct, alongside continuous high-flow nasal oxygen. Plan C represents a total shift in clinical priority. The sole focus is pure oxygenation. If Plan C yields no improvement, the provider must immediately abandon the mask and declare a CCO event. Cannot intubate, cannot oxygenate. This declaration must be vocalized loudly to the entire operating room. This specific human factors requirement instantly forces the team to assign roles for an emergency surgical intervention. Strict, unhesitating adherence to this downward sequence buys the clinician time. It forces the recognition of total airway failure before irreversible hypoxic brain injury. Front of neck access, or FONA, is the definitive surgical rescue for a CICO event. It bypasses the entire upper airway to establish ventilation directly through the neck. This illustration maps the midline surface anatomy, the hyoid bone, thyrohyoid membrane, thyroid cartilage notch, and cricoid cartilage. The target is the cricothyroid membrane between them. The safe zone is the lower two-thirds, avoiding the superior cricothyroid arteries above. To locate this precise target, providers use a tactile method called the laryngeal handshake. The non-dominant hand stabilizes the thyroid cartilage, allowing the index finger to slide inferiorly into the first soft depression. If the membrane cannot be palpated due to severe obesity or a massive hematoma, providers employ the hung modification, making a 10-centimeter vertical skin incision to manually expose the anatomy. Failure to accurately identify the cricothyroid membrane is the single most common cause of a failed FONA, resulting in false vascular passages and patient death. This diagram demonstrates the initial execution. Using a number 10 scalpel, the provider makes a confident 15mm transverse incision through the membrane. The scalpel is removed, and the index finger is thrust through to maintain the opening. The provider must physically feel the posterior tracheal wall to confirm correct entry. Next, a 15 French bougie is introduced, sliding parallel to the index finger and directed caudally into the trachea. As the bougie advances, the provider feels for tracheal clicks to confirm it hasn't created a false passage. The guiding finger is removed, and a 6.0mm cuffed endotracheal tube is railroaded over the bougie. After inflating the cuff, there is an absolute mandate to confirm placement using waveform capnography. Capnography is a monitoring method that measures the concentration of carbon dioxide in exhaled air. Relying solely on pulse oximetry or breath sounds is insufficient. Emergency FONA is a tactile, muscle memory procedure. It is specifically designed to succeed by palpation alone, ensuring airway securement even when pooling blood and secretions have entirely eliminated the provider's visual field. Surgical FONA is highly effective for adults, but is contraindicated in pediatric patients under age 8. This diagram highlights the pediatric airway, lacking a prominent thyroid cartilage with a tiny cricothyroid membrane. Providers perform a needle cricothyroidotomy, inserting a 14 to 18 gauge angiocatheter at a 45-degree caudal angle with continuous suction to confirm intratracheal placement. Pediatric needle access does not provide a definitive airway. It is strictly a temporary oxygenation measure that buys exactly 20 to 30 minutes before critical carbon dioxide retention occurs, serving purely as a bridge to a definitive surgical tracheostomy.